Coming this evening to our pancreatic cancer seminar. I am Leanne Parsons, and I am a volunteer with the Los Alamos Council on Cancer. I am a board member and also a facilitator for the Look Good, Feel Better program, and I also help facilitate the Reach to Recovery program for breast cancer patients and survivors. And I just do want to warmly welcome you to our evening's seminar and topic. I have the amazing privilege of introducing our fantastic guest speakers for this evening. And before I even start, let's just give them a round of applause, kind of loosen up. Yeah, and thank them for being here. The first speaker that I would like to introduce to you this evening is Dr. Katherine Morris. She has been an assistant professor in the Division of Surgical Oncology in the Department of Surgery at the University of New Mexico since December of 2010. She is board certified with both the American Board of Surgery and the National Board of Medical Examiners. Dr. Morris has completed a fellowship in surgical oncology with hepatobiliary and pancreatic focus and was the medical director of cancer research at Legacy Health in Portland. She has authored multiple articles, published in high-impact cancer-related journals, and offers 17 years of practice as a medical doctor to this seminar. So thank you very much, Dr. Morris, for being here. Give her a hand, ladies and gentlemen. I love that. She's devoted her life to being of service to each one of us. We are also welcomed by Ms. Ballinger. She is a genetic counselor with 30 years of experience in the field across many aspects of human genetics and disease. She is a diplomat of both the American Board of Medical Genetics and the American Board of Genetic Counseling. In addition to her current position of senior genetic counselor at the UNM Cancer Research and Treatment Center, she is a lecturer 3 for the Department of Internal Medicine and is an ad hoc instructor. I'm anxious to hear maybe a little bit more about that. I love it. Way to be of service. All right, for the School of Medicine as well as the UNM School of Nursing. Ms. Ballinger has a strong interest in medical ethics as they relate to genetic testing, as it has completed the Joan Gibson Healthcare Ethics Certificate course at the UNM. So let's give it up for Ms. Ballinger. Thank you, ladies, and I'm going to go ahead and turn our attention. And again, if you have not shut off your cell phone, please take a time to do that, and thank you so much.
All right, is this working okay? Everyone hear me okay? I have a soft voice, so if it dwindles down, please just raise your hand and yell to speak louder. Thank you all for coming out on a Thursday night to hear about not a terribly cheerful topic, but a very important topic, and a topic near and dear to my heart. Thankfully, I haven't had immediate family members suffer from this disease, but unfortunately, I've had lots of my patients suffer with this disease, and they do stay with you. So thank you for being here and for your interest. We have a lot to cover, and Ms. Ballinger and myself, we work in genetics clinic together, and I learn more about genetics from her every day than she probably has forgotten. So it's a great pleasure to have her here speaking with me, and we're going to kind of bounce back and forth. So we have one slide presentation, but we'll be going back and forth, and if we talk too quickly, please yelp, or quietly. All right, so there is a lot to cover on this topic. I wanted to start by discussing the basic anatomy, just so you guys are aware of where the pancreas is in your body, and I'm sure this is a pretty medically savvy audience, but if you're not aware, it's buried way in the back of our abdomen, behind the stomach, behind the left lobe of the liver, stretches all the way across. The majority of it is on the right side of the abdomen, and then it goes across and to the tail of the pancreas, which is right near your spleen. So it's an upper abdominal, very deep organ. And there's two major types of cells in the pancreas, one that make the digestive juices that allow us to digest fats and all of that kind of good stuff. And then the other component is the endocrine or hormonal component. And each of these different types of cells can form different types of cancers. So there's two prime different types of pancreatic cancer. And most of what we're going to be talking about is the most common type, which is pancreatic adenocarcinoma, or pancreatic cancer from the exocrine cells, or the cells that make the digestive juices. But I don't know if you guys caught the article in the Albuquerque Journal, I think the day before, talking about pancreatic neuroendocrine tumors. These are tumors that make hormones. They can make insulin, they can make glucagon, they can make all sorts of mischief. Those are an entirely different behaving type of pancreatic cancer. So most of the statistics that we'll talk about today are going to be, and most of the genetic syndromes, we'll be talking about pancreatic adenocarcinoma. It's the adenocarcinoma that has a worse prognosis, is more aggressive. It's the type of cancer that Patrick Swayze had. The endocrine cancer is what Steve Jobs had. So, in terms of incidence, it is our fourth leading cause of death for both men and women. It is not a very frequently diagnosed cancer, but it is extremely lethal. So there's roughly about 38,000, actually I think we're up to 43,000 a year, and unfortunately just a little bit under 90% of those patients will die of disease. And this is again the adenocarcinoma that I've switched to talking about. 45, I went ahead of myself. So these are the most recent statistics, an estimate of the number of cases that will be diagnosed in 2013. You can see the number is 45,000 diagnosed.
Your lovely mic is hitting your beautiful
Oh, thank you. Let's see if we can get the lovely mic off. There we go. How about I just hold it? That'll work. Thank you. So there's roughly just over 45,000 estimated to be diagnosed in this country in this year, and unfortunately over 38,000 of those patients will die of disease. It has a slightly more common predominance in men than in women, but the lifetime risk for all of us is only 1.5% on average, and this is of course talking about the average risk patient. In New Mexico, we'll have 3,540 patients who will die of cancer of all kinds, and 240 of these patients will be with pancreatic adenocarcinoma. We wanted to ask if there was a predominance. I figured we'd do a little local information, so we asked our cancer registrar if Los Alamos was a hotspot for pancreatic cancer, and thankfully it is not. There is actually a slightly lower incidence of pancreatic cancer here in Los Alamos than there is in the rest of New Mexico. And it is not statistically significant, but you can see the incidence rates. I think now I'm stuck on Los Alamos. There we go. Okay. So the point of this slide is to show you that we have made a lot of progress in cancer. It's one of the reasons that I think it's such an amazing field at this day and age to be in. It used to be that just under 50% of people would survive 5 years after a diagnosis of any kind of cancer. And we're now up to 68% of those people being diagnosed being saved and surviving 5 years. Unfortunately, if you look down at the numbers for pancreatic cancer, we haven't made as good progress. So we went from 2 to 4 to 6% 5-year survival for all comers for this disease. There are a lot of reasons. If people have questions about the research or the reasons why this is such a lethal cancer, I'd certainly be happy to address them at the end of the talk, but it is clearly a major health problem. And again, to put it in more of a perspective, we have our overall survival rates for colon cancer, which if we catch it early via colonoscopy or other screening methods is 90%. We have our 5-year survival rates for pancreatic cancer. If we catch it early and it's local disease, it's 23%, so a very aggressive cancer. The incidence seems to be increasing very slowly but very definitely, and it's increased 0.9% per year for the last 9 years that they recorded the incidence increase, and this is SEER data. We sort of hoped that we would see a drop in pancreatic cancer rates because smoking rates have gone down, which is fantastic. And unfortunately, our rates of diabetes and obesity have gone up. And so that's why most of us think we have this slight incidence increase. Just some brief words on staging. As most cancers are, these are staged from 1 to 4. 1 is when this is a cancer that is only 2 centimeters, so under an inch, smaller than a golf ball. to be stage 1, and it cannot have spread to any nearby organs or lymph nodes. I'm glitchy with the remote, sorry. There we go. Stage 2 is when the tumor has spread to nearby organs. So the pancreas, as you saw in that first anatomy drawing, and as you see in this one, is kind of tucked into the first part of your small bowel called the duodenum, and it's actually stuck to it. So often a pancreatic head cancer will grow into the duodenum, and that's sometimes how we find them. Stage 2B is when you have gotten to the lymph nodes. I need more hands. And stage 3 is when the tumor has spread to nearby blood vessels. So this is, we will talk about what makes a tumor something that I can cut out versus something that I cannot. And the key to that is blood vessel involvement. So stage 3 means it's gone to the important blood vessels around that area that supply your GI tract. Stage 4, as with most cancers, is when it has spread to distant parts of the body, with the most common sites for pancreatic cancer being liver and lungs. So when I was preparing for this talk, I was looking for risk factors that we can actually affect. We can't affect our genetics, we can't affect our family history or many of those things, but there are certain things that we can affect. And as I was going through it, I actually found one study that made me very happy. And it was a huge study of nearly 500,000 patients with 11.6 years of follow-up, and it got rid of the myth that caffeine is bad for you. So when I was growing up, everyone said coffee was related to pancreatic cancer and increased coffee intake is related to that. And thankfully I can say that no, that is not the case. Drink as much caffeine as you like. Yeah. Unfortunately, there are some things that we can do better to reduce our risk. So smoking is one of our biggest risk factors, and I think the most compelling picture that I have in mind was Patrick Swayze always had a cigarette with him, and that was his main risk factor for this disease. Increases your relative risk of getting this cancer by 2.2-fold. Heavy alcohol use is also a risk factor, increasing it by 1.45. And obesity, as defined as a body mass index of over 30, increases your risk by 1.26%. And I thought this was a particularly great statistic from a large review that showed that if you quit smoking, it reduces your risk to that of never smokers for this disease after 5 years. So if you're able to quit for 5 years, you're going to cut your risk down by 2-fold, which I think is very impressive. So I'm guessing there's not a lot of smokers in the room, but if there are, please stop. In terms of things that we may or may not be able to affect, I put diabetes on here. Having diabetes for more than 3 years does increase your risk of getting pancreatic cancer. There are certainly lifestyle changes that you can make to reduce your risk of diabetes, but some of us are just going to get it, and there's not much we can do about it. Obesity also, you could argue, risk modifiable, not modifiable. I won't go there. Interestingly, we're starting to see that patients who have a non-O blood type are at higher risk. So if you have an A blood type, for some reason, there's an association with increased risk of pancreatic cancer. Not sky high, not such that you should worry about it or consider screening. And we'll talk about screening for high-risk patients, but it is sort of an interesting finding, and I'm hoping that that sort of finding is going to give us a clue as to what is going on in this disease. For some reason, low socioeconomic status has a huge increased risk of getting the disease. Some people suspect that it's environmental in terms of diet. Some people suspect, pollutants. Some people suspect it's an association of smoking and lower socioeconomic status. But it is an independent risk factor when they do multivariate analysis. And chronic pancreatitis increases the risk a lot as well. So pancreatitis, inflammation of the pancreas, most commonly from alcohol, although gallstones are another risk factor for pancreatitis. Once you start getting an inflamed pancreas, it can continue to happen over and over again, and that chronic inflammation seems to increase it as well. There is also an increased risk of pancreatic cancer among Caucasians as compared to Asians, and among African Americans as compared to Caucasians as compared to Hispanics. So age is something that none of us can do anything about, and it is unfortunately one of the biggest risk factors for pancreatic cancer. So 80% of our patients are going to be diagnosed over the age of 60, and the median age is 71 years. We'll also discuss the genetic syndromes. I don't want to get ahead of myself there. And then I mentioned ethnicity in the previous slide. So in terms of assessing what a general risk is for the general population, this is diagnosed in about 8 to 10 people per year in the United States per 100,000 people. It's the 13th most commonly diagnosed cancer and is responsible for 6% of all of our cancer-related deaths. What we mentioned on the radio show was that it's about 1 in 69 women who get pancreatic cancer and 1 in 67 men in the United States. So it's not sky high. To give you a comparison statistic, 1 in 2 men will get cancer of some kind and 1 in 3 women will get cancer of some kind. So 1 in 69, 1 in 67 sounds a little bit better. And now I'm going to trade off here to Ms. Ballinger to talk about some of the genetic syndromes, also of which I think are rare but fascinating because they may give us an idea about what's causing this disease if we can learn more about them.
Thank you, Kate. I too have lost a family member to pancreatic cancer. My mother-in-law died 5 years ago of pancreatic cancer, so again, this is also near and dear to my heart. I have my little pancreatic cancer pin on here tonight. You know, this is for you, Mom. People want to know about cancers all the time. If I have a cancer, what is a chance my kid's going to get a cancer? Or what is a chance if my mother had a cancer, I'm going to get a cancer? And we worry a lot about cancers being hereditary. In fact, what we know is that most cancers are not inherited. Only about 10% of cancers are inherited, but almost every cancer has an inherited component. So I'm going to talk a little bit about some syndromes that we see pancreatic cancer in and the relative risk of that, or the percentage risk really, in terms of what they are. So this is just kind of an overview. These are all cancers of adenocarcinomas of the pancreas. So, and we will talk a little bit about the neuroendocrine tumors because those are important in genetics, but we're going to talk a little bit about these. So there's a number of, I give a talk called Pancreatic Cancer More Genetic Than You Think, and that's because there are a number of diseases, a number of syndromes in which we see pancreatic cancer. Can I get it to go? I can see it's blinking. The little red light's blinking.
Can we ask one of you guys to advance it for us?
But it's not changing. It's down, right?
Yeah, it's down.
Oh, maybe so. You know what? You could do it. Every time I turn the page, you'll know. Okay, that's it. We're just going to talk. These are the syndromes. Okay, so we'll talk a little bit about, while they get that going, about, can you advance it? Yes? No? Okay. We'll talk a little bit about, Dr. Morris talked about inflammation. There is a condition called hereditary pancreatitis, and people who have hereditary pancreatitis have very, very, very high risks of pancreatic cancer. Hereditary pancreatitis is known to have 2 genetic causes, but there are other families in which these do not cause the hereditary pancreatitis. These are mutations in a gene called SPINK and PRSS1. When you have hereditary pancreatitis, it's a very terrible thing. I don't know if anybody in here has ever had a attack of pancreatitis, but it is the kind of thing that knocks you off your feet because it is so painful. And if you have hereditary pancreatitis, I've actually seen a 2-year-old that's had to be hospitalized because of hereditary pancreatitis. And that's really scary because that's a long time of inflammation in that child. The risk of pancreatic cancer in patients who have hereditary pancreatitis is 33%. So that's probably our highest risk, is hereditary pancreatitis. So fortunately, hereditary pancreatitis is rare, but when you have it, it's a pretty awful disease, and the risks of cancer are very bad, and unfortunately, there's not a lot that we can do about them. There's another syndrome called Pucci-Jaeger syndrome, and you guys all have slides, so you can follow me along, so I don't have to really worry too much about that, except for I have to tell you the picture in the middle is not a Pucci-Jaeger polyp, because I have an actual one here, but I can't show it to you. She was making fun of me because I suddenly went, this is not a Pucci-Jaeger polyp. Pucci-Jaeger's is a syndrome that is a multiple cancer syndrome, but pancreatic cancer is one of the more common cancers. These are people that have very high risk of pancreatic cancers and other cancers, a lifetime risk of 93% of some kind of cancer. So genetic syndromes are rare, but if you have one in your family, cancers are not rare in your family, so the burden on an individual family can be very, very great, even though the syndromes themselves are very rare. Breast cancer is the most common cancer in Pucci-Jaeger syndrome. When you have somebody with Pucci-Jaeger syndrome, we've got one more, okay, one more. There are certain things that we see in childhood. We see this hyperpigmentation across the lips, on the fingers that is not present at birth and fades in adulthood. So it's not something that we see all the time. But these people have a type of growth that we call Pucci-Jaeger hamartomas. And these are not polyps in the same way that we think about the colon polyps that we get diagnosed when we have a colonoscopy, but those are dysplastic. When you think about dysplastic, you think about things like cervical dysplasia or a precancerous kind of thing. Pucci-Jaeger polyps are actually disorganized polyps. So they're not dysplastic, they're not on the cancer pathway, but they're disorganized tissue. And they have a very, I don't have the pointer now, they have a very characteristic appearance underneath the microscope. They have this sort of arborizing or tree-like polyp. That's why the one on your slides is not a Pucci-Jaeger polyp. And you can see the pigmentation across this young lady's lips here. People can have their colon full of these hamartomatous or Pucci-Jaeger polyps. And so they do have the ability to transform. Okay, so we're going to say, okay.
That way you can just say next slide when you're ready.
Okay. Oh, for them? Okay. Not do it here?
Not doing it.
Okay. They can transform into colon cancer, so colon cancer is another one of the things that you see in Pucci-Jaeger's. Fortunately, Pucci-Jaeger's is fairly rare, but it does have, again, a very high risk of pancreatic cancer, and in Pucci-Jaeger syndrome, this is one of the bigger causes of death in this syndrome. Next slide, please. Okay, so should I do this? Okay. There is a syndrome that, now who would think that pancreatic cancer can be related to melanoma? Doesn't that seem odd to you? Seems odd to me. There's a familial atypical mole and malignant melanoma syndrome, which we call FAM with 3 M's, in which we see both melanoma and people who have big dysplastic nevi, so big dark spots that if you biopsy them, they don't look normal under the microscope. They don't look like cancer because they're not quite cancers, but these are sort of precancers. There are some families that don't have the melanomas, they just have the pancreatic cancer. And in those families that have familial melanoma, because everybody who's got melanoma in their family now is thinking, oh my God, can we get pancreatic cancer? Just melanoma without a mutation in these genes do not have an increased risk of pancreatic cancer. So pancreatic cancer in this familial melanoma syndrome or FAM syndrome, the risk of pancreatic cancer under the age of 40 is less than 1%, but remember that's still a lot higher than the general population. By the age of 75, about a 17% risk of pancreatic cancer, so quite a bit higher than the general population. Then there are people who have genes that we know they must have, but we don't know what they are. And we lump all of these people into familial pancreatic cancer. They may not have any other cancers in their family. There are some other syndromes like Lynch syndrome, which is a colon uterine cancer syndrome that you see a slight increased risk in pancreatic cancer. But these are people that seem to be pancreatic cancer only families. So a lot of times when I'll see a family that has a concern about pancreatic cancer, there'll be multiple other types of cancer. But in some families we see just pancreatic cancer. I have a patient currently who is the 5th in 2 generations to have pancreatic cancer. So if you have, we know that there's some genetic component to most cancers that might be not as strong as a strongly inherited disease, and that's true of pancreatic cancer as well. So if you have one first-degree relative, a first-degree relative is a sibling, a parent, or a child, okay, so one loop away from you, the lifetime risk of pancreatic cancer is about 5%. So those of us who have a parent with pancreatic cancer or a mother-in-law with pancreatic cancer, my husband always says, I wonder if I got the pancreatic cancer gene. I always say it's not quite that simple, but he is at increased risk. If you have 2 close relatives with pancreatic cancer, that risk goes up to about 16%. So again, 2 relatives with pancreatic cancer is a little bit scary kind of thing. And 3 first-degree relatives with pancreatic cancer is probably some kind of syndrome with the risk of pancreatic cancer being as high as it is almost in hereditary pancreatitis. Now, when we look at family histories, and some of you in the room can attest to this, we ask you a lot of questions. Well, was he a drinker? Was he a smoker? And those odds may be, if there are environmental risk factors, we may adjust those odds a little bit. Lynch syndrome is the most common form of colon cancer, and it involves both colon and uterine cancers as the 2 top cancers, but we also see many other cancers in this syndrome, including cancers of the biliary tree and specifically pancreatic cancer with a risk of, as I said, much smaller than many of those other syndromes, of about 4%. And these tend to be they tend to be kind of family specific. So in families where there is pancreatic cancer, where there's Lynch syndrome, the risks seem to be higher than in families where there is not pancreatic cancer. Also, and I thank Angelina Jolie right now because everybody knows what BRCA is, right? I used to have to explain what hereditary breast ovarian cancer syndrome was, and now I just say Angelina Jolie, and people go, oh yeah, okay. So BRCA1 and BRCA2 are the genes that cause hereditary breast ovarian cancer. They're both genes that work in the DNA repair pathway, and with those, we see mostly breast and ovarian cancer, but we see other things as well. We see a high incidence of male breast cancer, and we see a high incidence of early onset prostate cancer, six-fold the population risk. Now, that's 6-fold under 60, so it's still fairly rare, as well as an increased risk in ovarian cancer. However, somebody noticed that there were some BRCA2 families in which there was a lot of pancreatic cancer. So in a 2003 study, they looked at families that had at least 2 first-degree relatives with pancreatic cancers, and they found that 12% of those patients had a BRCA2 mutation. So that's a pretty good correlation. And if you'd looked at those families to say, is there a lot of breast and ovarian cancer, and none of those families would have come to our attention via the breast ovarian pathway. They would have all been pancreatic. In the 2007 study, 17% of families with 2 or more cases in first-degree relatives had, so that's pretty consistent, 12 to 17%. So if you have the BRCA2 mutation, your risk is somewhere between 4 and 17%. And again, may be very much related to what we see in your family. So it may be more of a family-specific kind of thing. There is also a slight increased risk of pancreatic cancer with BRCA1 mutations, a relative risk of about 2.8, which is approximately equal to smoking, if I remember your slide right, 2.2, 2.8. My first pancreatic cancer family actually happened to be a BRCA1 family, so once burned, twice shy. So the relative risk is somewhere between 1 and 3%. So even with BRCA1, we do see increased risk in pancreatic cancer. BRCA1 is the gene that Angelina Jolie has. Then there is a rare syndrome that is of great interest because it's the gene that's mutated in this syndrome is really a gateway gene. And if you look at all cancers, you know, cancers are caused by accumulations of mutations. Okay? So all cancer is genetic, it's just not all inherited. Okay? So we collect mutations, and one of the reasons that cancer increases as we get older is the older we get, the more mutations we have collected. Okay? And if we look at almost any cancer itself, and I always like to tell people, you know, cancer really, when you have a cancer, it really is an alien. It has a whole different genome than you do. Okay, it has its own different set of mutations, and if you compare it to your normal body DNA, it doesn't look the same. But in most cancers, we find mutations in this gene called TP53. And there are some people who are born with mutations in TP53, and they have a syndrome that we call Li-Fraumeni syndrome, after the two doctors that named it, that described it. Lifetime risk of cancer is very high. Remember, this is really the gateway gene. This is mutated in almost every single cancer. So you can imagine if you're born with it mutated, you're going to see early cancers, you're going to see childhood cancers, we see a lot of blood cancers, brain cancers, bone cancers, breast cancers in women as young as 16. So a really not good thing to have. And the risk of pancreatic cancer in this syndrome is about 1 to 2%. Again, quite a lot higher than it is in the general population. The problem with folks like this is what do you look for in these patients as we go on to talk about screening for pancreatic cancer, because they're really at risk for almost any cancer. I'm going to talk briefly about the neuroendocrine tumor syndromes because, number one, some of them are a little more common. But remember, neuroendocrine tumors have a higher rate of survival. They're a much more indolent cancer than the pancreatic adenocarcinomas. But pancreatic adenocarcinomas, there's a couple of syndromes that if somebody has a neuroendocrine tumor of the pancreas, they come to me, no matter the age, no matter what. And Dr. Morris has one that I just told her yesterday, you need to send me this patient. Von Hippel-Lindau disease is a disease of multiple tumors. You can get tangled blood vessel tumors in your brain and spine called hemangioblastomas. We see an increased risk of renal clear cell carcinoma, which is the most common type of cancer. And in fact, in sporadic renal cell carcinomas, we always find VHL mutated. So not mutated by hereditary, but just mutated by life and age. And you get these pancreatic islet cell tumors, and the risk is about 17%. Now, this is a kind of pancreatic cancer that Steve Jobs has. I don't know that he had von Hippel-Lindau syndrome, but he had this kind of pancreatic cancer. The problem with Steve Jobs is he decided to treat it with non-allopathic medicine for 1.5 years before he actually got any actual medical treatment. Most people, many people who have neuroendocrine tumors do not die of their disease. So that was really kind of a sad thing for those of us that work in the pancreatic cancer communities, to see somebody die of pancreatic cancer who really didn't need to. It's a rare disease, about 1 in every 3,600 Americans. 20% of the time, the person with von Hippel-Lindau disease is the first one in the family, so they're what's known as a de novo mutation. So when they were conceived, when the egg and the sperm came together, the VHL gene was mutated. Multiple endocrine neoplasia type 1 is the other thing that we would test anybody with a pancreatic neuroendocrine tumor for. And these people have hyperparathyroidism, which means they have calcium problems. They have sort of, I still have a hard time with carcinoids. They're sort of
It's a slow-growing cancer that can spread.
right.
So it was actually described by a German in 1851, and he called it a carcinoid because it wasn't really a carcinoma, it wasn't aggressive. And so, of course, we translated that in.
Right, so it's kind of a not exactly a precancer, but fairly indolent. They have cancers of the gastroenteropancreatic tract, so they get these neuroendocrine tumors, and the incidence is about 1 in 30,000. So when we screen for pancreatic cancer, because that's what everybody's here, can you tell me? Let me go ahead and give this back to Dr. Morris, and we'll talk about that.
And this is where we really go back and forth a lot. But you know, the whole goal of screening for cancer, obviously, is to catch it at a stage where we can do something about it. And unfortunately, with pancreatic cancer, right now, 7% of our patients are diagnosed at stage 1. And the survival goes down precipitously after that stage. So we're looking for ways, how can we find this better? How can we find it sooner? Over 50% of the patients that I meet with a new diagnosis of pancreatic cancer already have metastatic disease, which means that this is not something that we can cure. However, if we can get the disease at stage 1, we have a 78% chance of long-term survival or survival beyond 5 years. So it's sort of the holy grail of how do we find this disease, how do we find it early when the symptoms are vague, the organ's buried way in the back of your abdomen. Most people have no symptoms until suddenly they have a lot of symptoms. And because it is not a very common cancer, 13th most common cancer in the United States, we're not looking at a population-based screening situation like we do with colon cancer or prostate cancer, although that is a whole nother talk, or breast cancer. So we're not talking about screening the general population. What we're trying to do, since we don't have very good screening tests, is focus on the patients that are at high risk. And there have been a few studies where they've taken families that have these genetic syndromes that are at high risk, and they have been able to find some sort of abnormality or a lesion within the pancreas in about 5 to 22% of the patients who get screened. The problem is we don't always know what those lesions or changes or abnormalities mean. So one of the ways that we try to figure them out is we say, well, is there a blood test? CA19-9 is a blood test that we will often use. It's a tumor marker that is elevated in most patients who have pancreatic cancer, but there are a lot of patients with no pancreatic cancer and who will never get pancreatic cancer who have elevations in their CA19-9. So it's not a great screening test because we have a lot of false positives. 5% of the population can have fully widespread metastatic disease, and they will have a normal, or they'll actually have no CA19-9 because they don't make the protein. So it's a normal protein that we make that seems to be elevated in some benign conditions, but also in pancreatic cancer. We've looked for mutations in other genes. Lori mentioned the P53 gene, another gene called KRAS. And if we see abnormalities, if we get fluid from the area of the pancreas and we see abnormalities in these genes in that fluid, we think, aha, we're onto something. We're going to be able to diagnose this early. Not so much just yet. We're also looking at other tumor biomarkers. I've listed a series of them here. And then there's been some exciting work in microRNA. So RNA, I probably don't need to tell you guys this, but our genes go from DNA and then they get translated into RNA. And the RNA is what tells us how to make the proteins, or tells our body how to make the proteins. And so there are whole fragments of RNA floating through our bodies, and certain ones of them that are very tiny and don't seem to actually code for a protein, so they don't go on to make a protein, but they seem to be floating in our body for reasons which we don't understand, and they are associated with pancreatic cancer. So there's a lot of really great science that's going on in this field, but we haven't been able to deliver it to be useful yet to patients, unfortunately. Imaging is a great thing. I remember when I was in med school, there was a big fad for the life scan. You know, go to the mall and have a CT scan from head to toe. Bad idea. Bad idea. It was a horrible idea for many reasons. One, we didn't think about the radiation exposure of CT scans back in the 80s and 90s. And two, we come up with a lot of findings that we don't know what to do with. And that often leads to a lot of invasive procedures with risk for complications and problems. So imaging has many pitfalls, but in a clinical trial setting, in a high-risk patient, it may actually play a role. The imaging that we commonly use when we're looking at the pancreas is cross-sectional imaging like CAT scan or MRI, which does not have the radiation exposure but has some disadvantages in terms of what we can see. And then EUS stands for endoscopic ultrasound. And this is a relatively new, in the last 10, 15 years, technology where the gastroenterologist will actually I should say they'll make you sleepy first, and then they'll put a large camera down your throat into your stomach, and on the tip of the camera is an ultrasound probe. And I don't know if you recall that first picture where the pancreas was lying right behind the stomach. They can pretty much put that probe almost right on the pancreas and get the best look of the pancreas that we'll ever get outside of what I get to see in surgery. So endoscopic ultrasound, while invasive, is a very, very good test for looking at the pancreas. FNA is fine needle aspiration or a needle biopsy. So that's the other thing. They have a camera, they have an ultrasound probe, and then they have a very long, thin needle that snakes down through that camera. And they can actually go through the stomach or the duodenum and take a sample of anything that they see in the pancreas. So you would think that we would be able to find these early and to find them successfully, but it's been somewhat of a challenge. And these are some of the current guidelines, a recommendation of a consensus conference on gastroenterologists. Unfortunately, there's also many other consensus conference guidelines that recommend slight variations on this or completely different things, and that pretty much should tell you that we're at the level of expert opinion, which is not very scientifically rigorous. I don't know if you want to talk about the, oh, okay. So the recommendations are, and the one thing that all these different consensus groups agree on is that if you're going to try screening for pancreatic cancer, it should be done in the setting of a clinical trial. There are programs that have been brought up where people do screening, and if it's outside of a clinical trial, we're never going to know what works and what doesn't work. And so every single screening body does recommend all of these things be considered only in the setting of a clinical trial. So EUS, as I mentioned, endoscopic ultrasound, that is recommended for consideration in a patient who is a first-degree relative of a patient with pancreatic cancer in a family with multiple pancreatic cancers. So one would not put you into this category. Somebody who has that FAM mutation or CDK2NA, you always rattle it off faster than I do, is somebody with an elevated enough risk to consider screening. And then carriers of the BRCA2 mutation who have a first-degree relative with pancreatic cancer are considered eligible, as are the patients with Peutz-Jeghers and a carrier of Lynch syndrome who also has a first-degree relative with pancreatic cancer. So these are pretty tight recommendations, but for these patients, it is something to consider. And I didn't mention what MRCP is, and for anyone who's wondering, that's a magnetic resonance cholangiopancreatography, which is essentially an MRI scan where they are able to recreate the biliary tree on X-ray. And they're absolutely wonderfully accurate pictures of your biliary tree, which is what drains the liver, and of your pancreas. So that's something that people are also talking about doing, but I think most of us feel that endoscopic ultrasound gets us a better look at the pancreas, and you can get tissue. If you just have an MRI, there's no way, you're not right there, you can't take that needle sample. However, the MRI does not expose you to the endoscopy, which is sedation, and the risks of perforation of your GI tract, which is about 1 in 100. So I put this slide in mainly, we know a lot about pancreatic cancer. There's a lot of incredibly brilliant scientists working on this. We've learned about many of these genetic events that occur within the actual tumor itself, as opposed to what Lori was talking about, which is a mutation that occurs at the time of conception. So we've learned just an amazing amount of things, and our pathologists have got very good at categorizing these lesions or these findings that we might see. And so they'll categorize them with a variety of different terms that you see up here, and we can attach certain mutations to these different categorizations. And so, again, we know all this, and yet we still haven't really been able to figure out what these type of lesions will do. So we think that PAN-in3 is worse than PAN-in1, is a higher grade abnormality and more of a risk to develop cancer, but we don't honestly know that. We think that some IPMNs, which is we think a pre-malignant lesion in the pancreas, can go on to develop pancreatic cancer. But again, we do not know that, and there are plenty of people who have IPMNs who never go on to develop pancreatic cancer. So we have a lot of information, but unfortunately, we're really only seeing the tip of the iceberg. So that's my pretty iceberg picture. And it's unfortunate, and it's really tragic, because what would be so ideal would be able to, have someone take a blood test and say, okay, yeah, you've got, early pancreatic cancer, and then I have a chance to help them. Next, thanks. So the screening pitfalls I've already kind of gone over. We're finding abnormalities. We think they might be pre-malignant, but we're not talking about taking off a lump on your skin. We're talking about taking out a part of your internal organs, and it carries about a 1 to 3% mortality risk, even if you have it done by someone who does it all the time. So this is not a small surgery. It's not something that can be considered lightly. So it's a heavy burden to bear, knowing that you have something that might be pre-malignant in an organ that I can't take out without, a pretty significant cost to you as a patient. Even in the high-risk patients that are being screened in some of these studies that we mentioned and that Lori will discuss, some of these patients end up going on to get metastatic disease. So we just haven't really figured out how to do this well yet. And to discuss some of the studies, this is your slide.
So there have been a couple of screening studies done. One with 78 high-risk patients. They had either familial pancreatic cancer, as defined as more than 3 relatives within a family, or 6 with Peutz-Jeghers syndrome, the one with the spots on the lips. And of that 78, 17 of those that had familial pancreatic cancer had findings that were suspicious for cancer. At the time this study was published, 9 were still under surveillance. 1 had actually gotten a fine needle aspiration of that and did have a pancreatic cancer. And there were 7 who underwent surgery. Now, surgery is a Whipple, and Whipple is removing your pancreas. Or a distal, yeah. She'll talk about the surgeries a little more. They did find 8 people who had a confirmed lesion. However, 6 of those were benign intraductal lesions. So you've given somebody your pancreas and it wasn't cancer. That is a little bit scary to me. They did find one that progressed to an invasive adenocarcinoma, and then they had one that was actually a carcinoma. So when you do screenings for things that you don't know if they're going to become cancerous or not, and if you have a skin lesion and the doctor goes, I don't really like the way this looks, then you go, okay, take it off. That's really different than saying, there's a little something in your pancreas, and you go, well, take it out. So I think that's part of what we struggle with trying to find these neoplasms early, is that, as she said, if you have some of these procedures, the mortality of the procedure itself may be as high as 3%. So, well, you want to hand it back here? Okay,
Sure,
we're
we'll
just
go for it. Now we have 2 microphones, so we're really in trouble. So we think where we think this is going, but not is yet, is that we're going to be doing a combination of imaging and the biomarkers that I talked about. So most of us in the field think it's going to be the best screening, which, again, who to screen and how, we do not know, but we suspect when we know who to screen, the best screening is going to be a combination of the endoscopic ultrasound or the MRCP and some sort of sampling of the juices in the area and looking for these changes in DNA or biomarkers. Again, not there yet.
So there's a lot of debate in the medical community regarding whether or not we should be screening for pancreatic cancer. And in fact, if you look at the National Comprehensive Cancer Network guidelines, for those syndromes like Lynch syndrome or BRCA2, they actually say there's no evidence-based data that says we should be screening, so we make no recommendations for screening. In contrast to the consensus, to the gastroenterologists. But in those populations that are at very high risk, there may be a role for screening in highly selected populations. So this is not for people like my husband, whose mother was 75 with pancreatic cancer and doesn't have any other family history of pancreatic cancer, but in people who we can really pinpoint as being very high risk. So I think that, we get to this point in the talk and people go, so you've told us this is a really bad cancer. You've told us that the screening is not very effective, so really why are you here? And the point is especially in those that are high risk, and again, this is where the genetics people come in. So those are the people for high, because it's the hereditary pancreatitis, although non-hereditary chronic pancreatitis is also a risk. It may help us identify family members at risk, and it may help us find out about other cancers that people are at risk for. So, when we're
That we can screen for.
that
and
we can
treat.
screen for better than this. So we're still working on getting to pancreatic cancer very early, but sometimes looking at a family history, diagnosing pancreatic cancer as part of a syndrome in a family can help us, maybe not with the person who gets the pancreatic cancer, but help us prevent some of the other cancers.
So I was just going to go forward to talk about some of the signs, symptoms, workup, and what to expect if, heaven forbid, you are diagnosed with this disease. And the symptoms and signs you can see are somewhat non-specific. There's plenty of people out there who have unexplained weight loss. There's plenty of people out there who may think that their stools are particularly foul, but that is a real sign. Their clay-colored stool is usually a late sign, and that is actually when your bowel movements turn from brown almost literally to the color of this paper. And the reason for that is because the pancreatic cancer has blocked the drainage of bile from your liver, so you have no bile in your GI tract, and bile is what turns our stool brown. So unfortunately, as you can imagine, clay-colored stools, while pretty specific and unmistakable, is a late sign of pancreas cancer. Jaundice is when you turn yellow, so your urine turns tea-colored, your stool turns white, and you turn yellow, and that's all because of that biliary duct getting blocked. Again, a late sign. Persistent upper abdominal pain, and this is described as a boring or gnawing pain that is unforgettable and not mistaken for anything else. It is a pain that continues. It wakes people up in the middle of the night. It goes through to their upper back like someone's drilling into your upper abdomen. Also, unfortunately, a late sign. One of the things that we're starting to notice that may be an early sign is a patient who gets diagnosed with type 2 or adult onset diabetes with no risk factors. So this is someone who is not overweight and has no family history for diabetes and suddenly becomes diabetic, or suddenly has pancreatitis for no particular reason. That always raises the hair on the back of our necks, and we start thinking about this disease. But again, if there's nothing that I can see on imaging, and things have to be over 1 billion cells big for me to be able to see them on imaging, there's no way for me to find it. So I hesitate to put the signs and symptoms page up there because it's kind of like in medical school, you get every disease known to man, or you think you have every drastic disease. So please do not take home the fact that you have something horrible from this. If we are suspecting a pancreatic cancer, if someone comes in with clay-colored stools, or someone comes in with that kind of pain, or gets a CAT scan because they're in a car accident and we see something unusual on the CAT scan, this is the workup that you can expect. We'll start with finding a mass, and then sometimes we're able to get a biopsy using CT guidance. Sometimes we have to do that endoscopic ultrasound and the needle biopsy that I talked about. Sometimes we see masses in the pancreas and we do biopsies, and the biopsies are either described as suspicious or atypical or completely normal. We still do not ignore those masses. A suspicious-looking mass on a CAT scan, and I'll show you a couple of examples on CAT scans, is not something to be ignored. And in fact, I often have to take patients to the operating room for one of these major surgeries without a tissue diagnosis, without proof that they have cancer. And so I prepare them and I say, there's about a 3% chance that I'm going to take this out and it's going to end up being benign. And frankly, if it is benign, I'm sorry I put you through a big surgery, but I'm really happy because that means you're not going to have this come back. So this is one of the very few cancers that we actually treat without knowing 100% what it is before, and that's because it is such a concerning finding. We don't have time to wait and see if it grows like we do with some other things. Treatment for this disease usually involves multiple physicians, so you end up with this herd of doctors. You end up with a surgeon like myself, you end up with a radiation oncologist possibly, and a medical oncologist for chemotherapy like Dr. Bernstein. It's not always in that order. It used to be always surgery and then chemo and then radiation. Things are now changing. So anyone who is dealing with this as a potential disease needs to go to a physician that does a complete head-to-toe physical exam. So somebody that asks all the nosy questions about family history and about what color your stools are, and somebody who's going to really listen to every symptom and odd change that you've had. Usually we will do, when we're suspecting the disease, that blood test, the CA19-9, and if it's elevated, again, does not mean you have pancreatic cancer, but it makes us concerned. If it's extremely elevated, that actually makes us concerned that there may be spread of the disease. So there are certain levels that kind of give us hints or clues, but they're not 100%. Next up is usually a CT scan or an MRI, and PET scan has some role in answering some questions, but it's actually not as useful as you might think it is. And PET scan is where we give you the radio-labeled sugar, and it goes to areas in the body that are using a lot of sugar, which is either an area of inflammation or an area of malignancy. The endoscopic ultrasound we talked about. Now, if somebody presented with a CAT scan and obviously had widespread metastatic disease, there would be no reason to put them through the risk of the endoscopic ultrasound. So that, if we're talking about doing that, it usually means this is something that we have a shot at curing. We talked about the biopsy, talked about the false negative rate for biopsies. So it's actually quite high, even though we end up taking probably about 20 to 30% of patients with no tissue diagnosis to the operating room. Only 3% of those patients are going to hit the lottery and have a benign result. In terms of what I look for surgically, and this may be a little bit difficult without the pointer. Let's see if it'll work. Oh, it does. Yay, okay. So these are both CAT scans. So these are studies that are slicing you like a loaf of bread, and it's as if you're looking up through from the feet up to the head, okay? So these are the kidneys, this is the spine, the belly's up here, this is stomach, and the arrows are pointing to the superior mesenteric artery, which is the artery that supplies blood to your entire GI tract. You cannot live without it. And next to it is the vein that drains your entire GI tract, the superior mesenteric vein. This dark thing right here is cancer in that head or front part of the pancreas. But this is something that we can take out. You can see that there's normal looking black tissue, which is actually fat around those blood vessels. So those blood vessels, while nearby, are not stuck to the cancer. And that makes this clearly resectable. And in most cases, a patient with a CAT scan like this would be recommended to undergo surgery first. So if you contrast that to this one, this is these are at different levels in the body because there are two different patients. This is liver, again, kidneys, backbone. You can see this dark, ominous mass. This is normal pancreas. That is tumor. This is showing that the tumor is actually stuck to that vein for about 180 degrees. It is not at the artery, which is good, but when it's stuck to the vein like this, we consider them borderline resectable. And in general, most patients now will undergo chemotherapy first before surgery, or chemotherapy and radiation. And we'll talk about the pros and cons of that in a sec. We can take, we can take the superior mesenteric vein out and reconstruct it, and that's not uncommon that we have to do that for this cancer. But if it is touching that vein, we generally say this is a pretty advanced disease and we want to treat the whole body before we go in surgically. And that's the rationale behind it. Unfortunately, when we give people chemotherapy up front for a borderline resectable situation, about 25 to 30% of those patients will actually show up with metastatic disease before we can go to the operating room. And on the one hand, sometimes families think, oh, I missed my chance. But most of us who do this business know that if spread shows up that quickly, it was there already, and that my surgery would not have helped them. So does that make sense to everyone? Okay. It's a little bit to wrap your mind around when it's actually you that we're talking about. This is clearly unresectable disease. So you see those two blood vessels are completely obliterated by that tumor that is really stuck to them and kind of hanging on to them like a crab. And the reason this is unresectable is not because we can't cut an artery out and put it back together, because we do that all the time for patients with vascular disease. What we learned in the 80s and 90s when we did take this kind of a tumor out is we would do this huge resection, and we would reconstruct the artery, and we'd reconstruct the vein, and we'd think we'd done someone a big service, and unfortunately they had the same life expectancy as someone who had no surgery at all with this disease. So we've learned that if it has gotten to the artery, it's not something we're going to be able to cure with surgery. And then the other picture shows you metastasis or spread to the liver. So all these dark spots are sitting in the middle of otherwise normal-looking, healthy liver. And that's also not something in pancreatic cancer that we can take out and help. Now, colon cancer is another story. We can actually resect metastatic colon cancer and have long-term survivors and cures. Pancreas cancer, not yet. So in terms of the surgery, most of us who do this actually start by putting a camera in the abdomen at the time of surgery. And so a patient goes off to sleep. We're prepared to do the major resection. And then we make about a centimeter incision around the belly button and put a camera in and look all at the lining of the abdominal cavity. Because even with our endoscopic ultrasound, even with our MRI, even with our CAT scan, about 5 to 10% of the time there's going to be little tiny, the size of rice flecks of metastatic cancer on the lining of the abdominal cavity. And I would sure hate to, once it has spread outside of the pancreas and once there is that metastatic disease, me making a big incision and giving you a major operation is not going to help you, it's going to hurt you. So we start with the laparoscopy, or putting a camera in, and then we resect the area of the pancreas where the tumor is. And that falls into two main categories. So the Whipple procedure, or the pancreaticoduodenectomy that Lori mentioned, is this first procedure. And we have to resect everything that's colored gray. And the reason for that is because all of those organs are stuck together. So there's no way to just take out the head of the pancreas. Everything is literally stuck, it's sealed to each other. So what you're left with is half the pancreas, usually half the stomach or all of the stomach. It depends on, sometimes we don't have to take all of the stomach. And then you're left with a bile duct that has to be hooked up. So we hook up the pancreatic duct, the bile duct, and then we hook up the stomach or the GI tract. So it is kind of one of the grandfathers or biggest surgeries that we do. Usually takes about 4 to 6 hours, and it carries a 1% mortality even at Sloan Kettering, which is where I trained. So it's a big deal, and that's why prophylactic pancreatic surgery, or taking it out before it can become cancer, is such a hard thing to consider. If you sort of get lucky and have your tumor in the back part of your pancreas, the surgery is actually much more simple, and that involves taking out just this back part. The back part is very closely approximated to the spleen, so about 50% of the time the spleen ends up coming out with the back part of the pancreas, but thankfully in adults that's actually not a terrible thing. So the downside of having cancer in the back part of your pancreas is that generally when we find these, this one, if it grows to 2 centimeters or 3 centimeters, it blocks the bile duct and we get symptoms and we know about it. These, often we don't get symptoms until it's very, very large. So I've actually seen some of these be the size of a basketball before we find them. Yeah. And they can involve a bunch of surrounding organs. They can involve the adrenal glands, which are in that area. They can involve the back of the stomach, part of the colon. So it can end up being a very major resection. If it is just in the tail, however, it's that much smaller surgery. A lot of the data that came out in the 90s and 00s when I was training was looking at which surgeon should take out your pancreas. So when I was a general surgery resident, it's kind of interesting because it's been my career that this change has taken place. But when I was a general surgery resident, general surgeons did pancreatic resections on a regular basis. And because pancreatic cancer is a rare disease, most general surgeons would do 1 a year or 1 every 2 or 3 years. And in the 90s, they started looking at this and they started finding out that, as you would expect, if you do something more frequently, you tend to do it better. And so a lot of the studies that came out have shown that high-volume surgeons and high-volume hospitals, because it's not all about the surgeon, it's about the nurses, it's about the respiratory therapists, it's about physical therapy, it's about ICU nurses who know when someone's getting sick before they actually get there. So high volume hospitals and surgeons did have better outcome, lower mortality, and sometimes that mortality would be as different as 20% versus 1%, so big deal. What I thought was so interesting when we actually started looking at these studies and these papers is that they define high volume as 4 to 6 resections in 1 to 2 years on most of these studies. So when people hear high volume, they think, oh, you must do 80 pancreatectomies in a week. Well, no, that's not high volume, thankfully. So most of the guidelines now are recommending that if you have to have pancreatic surgery for pancreatic cancer, that you go to a place where you do more than 15 a year, roughly. And that's for the surgical standpoint. I think part of the reason for this is just if you do it a lot, you get good at it, and part of it is the support team. If the nurses see something over and over again, they get better at it. And part of it is the fact that in a bigger center, you know, I'm very fortunate. I can walk across the hall and talk to a medical oncologist about a complicated situation. You know, they're right there. I can call them up. I can text them. It makes things a lot easier to involve all the different team members who really make a difference in the outcomes. In terms of if you go through surgery, what are my predictors of recurrence? Unfortunately, it's very high. This is a hard conversation to have with a patient, even who has an early stage disease, because we know from those survival statistics that even a patient who I can get all of their tumor out, any lymph nodes that are involved out, about 80% of those patients are going to suffer recurrence or metastasis within the first 5 years. So it's a huge price to pay surgically, and it's the only shot, but it's not a great shot. And the reason for that is that we need better chemotherapy. We have decent chemotherapy now, and if someone is going for cure, we strongly recommend and try to get them to the medical oncologist and get them well enough to start chemotherapy within 4 to 8 weeks, because that's the time when theoretically there should be the least amount of disease, and it's much easier to kill small volume cancer cells than it is to attack larger volume cancer cells when they develop resistance. Radiation therapy, again, when I was in training, everyone who had pancreatic cancer after surgery would get both chemotherapy and radiation. That underwent a huge change in my fellowship because of the results of one study from Europe. It was a very, actually I'll get to that study in a sec. In terms of chemotherapy, the most commonly used one is something called gemcitabine. This is a chemotherapy agent that inhibits the synthesis of DNA and RNA, so you can't make the DNA, you can't make the RNA, so you can't make the protein, so the cell goes on to die. And that's how it works. The side effects are what you would expect from something that inhibits cells from growing new ones. You have low white count, you have low platelet count, so there's increased risk of bleeding and bruising. You can get anemia because our blood cells, white cells, platelets, red cells are always turning over. Nausea and vomiting, unfortunately, is a common side effect. However, this is a much better tolerated chemotherapy than the chemotherapy that a lot of patients have had. So if you've seen a patient go through breast cancer chemotherapy, for example, and they really do suffer from a lot worse nausea and vomiting than patients on gemcitabine. So that's not a very ringing endorsement, but nonetheless. Fatigue, fever, and then sometimes an acute allergic reaction like swelling of the arms and legs. The benefit, however, is pretty decent. So if I can take out someone's pancreatic cancer and they get chemotherapy, it actually increases their chances from 9% survival at 5 years to 21%. So that's actually a pretty good bargain. Now, when you look at it in a different way, it doesn't look quite so good. If you look at the median survival, we're talking about 22.8 months versus 20.3 months, so just a little bit over 8 weeks. So it all depends on how you look at it, and it depends on what your goals are. The radiation, there we go. The radiation trial that I was talking about was called the SPAC trial. It stood for European Society of something something. And they did a huge trial all across Europe. They had 4 arms to the trial: patients who just had surgery, patients who just had chemotherapy, patients who had chemotherapy and radiation, and patients who had chemotherapy before surgery. What they found in this trial was that if you had surgery and chemotherapy, you did the best in terms of survival. They also found that if you had surgery alone, you did better than if you had surgery and radiation. So radiation, they concluded, actually gave you worse chances than not doing anything. Needless to say, this has been very widely debated and critiqued, and it's one of the first studies that have shown this. All of our studies prior to this showed that radiation and chemo did better. In America, there's still a big trend towards doing radiation for pancreatic cancer. In Europe, nobody does it at all. Patients often ask me, well, what would you do, doctor? And the honest answer is I have no idea because I haven't been put in that spot. But honestly, based on my understanding of this literature and on some of the other studies that have come out after that, I probably would not have radiation, except in very specific circumstances. So this was a huge game changer that came out in 2004, right in the middle of my fellowship, and has been a big question. The one time that if it was me, I think I would consider radiation would be if the margins or the tissue where they took the cancer out had tumor cells at the edge of what was taken out. So a positive margin, meaning tumor cells at the edge of what was taken out, is something that would make me think, hey, maybe a local treatment like radiation to that area might be able to help get rid of any cells that were hanging out. If the disease is metastatic, if it has spread outside of the pancreas, spread outside of the local regional area that I can take out, which is pancreas and lymph nodes, then we know that we don't know of any cure for this. Chemotherapy does seem to benefit patients, and they've actually looked at chemotherapy versus no chemotherapy in terms of quality of life, which is clearly, I mean, that's what it's all about. And the chemotherapy group actually had better reported quality of life than the patients who did best supportive care or palliative or symptom management care in pancreatic cancer setting. So this is one of the few cancers that if I had metastatic disease, I would consider chemotherapy for. And that's because that was a pretty well done study. The chemotherapy, I think the reason for it is that the chemotherapy, as I mentioned, while I had that long list of side effects, it's actually one of the better tolerated ones that we offer people. So I think it gets you a fair amount and doesn't cost you as much as some of our other treatments. But another very reasonable option is palliative or best supportive care, and that's where the goals are all symptom management, really focusing on trying to keep you feeling as good as possible for as long as possible. We continue. I said I was going to talk about new treatments for pancreatic cancer, and there are some very exciting things that are coming out of the lab, but have not made it into clinical. Oh, sorry. Can you go back one? Get rid of the headshots. There are some very exciting novel agents that we're looking at for treating pancreatic cancer. People are looking at things. One of the reasons pancreatic cancer is so resistant to chemotherapy is it forms this dense scar tissue around itself, and it's almost like it's got a shield on. And so we're looking at some agents that can break through the shield and have the chemotherapy on their back and kind of get in like a Trojan horse and be more effective. Those are starting to come out. But in terms of things that are really well accepted and have been through the large kind of trials that get a new treatment course to patients, we're still trying different versions of the same drugs. So the new drugs are starting to come out, but they haven't hit yet. And we don't know how effective they'll be. There's plenty of things that we thought were going to work like a charm that didn't, unfortunately. This is the thing that most people have heard the most about recently, and so I wanted to talk about it. FOLFIRINOX is a 4 chemotherapy regimen, so 4 different drugs. It's also used in colon cancer. And so you have your 4 drugs, or a lot of the medical oncologists kind of call it the kitchen sink. We throw everything we've got at you, versus that single agent gemcitabine. And where we threw the 4 drugs at people, they had a 30% response rate. And response rate means that some of your tumors shrunk by 50%. Or thankfully, some patients actually had complete responses that lasted for a little bit of time. So response rate at 30% is not great, but it is better than the alternative. The survival advantage, when they presented this trial, it was the first trial recently in sort of modern days that had shown any benefit of a chemotherapy agent for pancreatic cancer. There was great excitement about it, but overall survival, we're talking 11.1 months versus 6.8 months, so not huge. And this one does not have the quality of life data behind it, and it comes with some significant side effects. Very severe diarrhea in 12%, neuropathy, which is numbness and tingling and nerve damage on the extremities, 9%, and white count that will land you in the hospital because it's so low, about 45%. So, oh, excuse me, I forgot. They did follow this initial study up with a quality of life study, and they did find better maintenance of quality of life in the FOLFIRINOX, or the big chemo group. Honestly, having seen patients go through both of these different treatments, I suspect that that is selection bias on the patients who made it into the trial and were healthy enough to get a 4 chemotherapy agent regimen. So it's something that we've finally been able to make some progress from the 90s, but I think it comes at a pretty high price, and I have much more high hopes for the drugs that I was talking about, the drugs that modulate inflammation and that modulate the immune system, and that some of these Trojan horse types of agents that are coming in. And then the last slide was just the headshots. Poor Lori is the sole genetic counselor. I thankfully get to work in a team, and so I just wanted to put up the team members. These are the other members of the Division of Surgical Oncology, and we all have our different areas of the body that we work in that you can see there. We have 2 new faculty members, and that's another reason I wanted to put this up here. Dr. Bridget Fay just joined us, and she trained with me at Sloan Kettering. We were fellows together, which is really fun, so I've known her for a long time. And her specialty, my area of emphasis is the liver, the pancreas, the upper GI tract. Her area of specialty is colorectal cancer and also palliative care. She's one of the few surgeons in the country who's board certified in palliative care or symptom management, and that's training that she went on to do after the fellowship that we did together. And then also, we were just able to recruit Dr. Anna Volterra, who practiced in Santa Fe for quite some time and did a breast cancer fellowship at Johns Hopkins. So she is concentrating on breast cancer, both cancer and benign disease, and just a phenomenal addition. And these guys just joined us in the last couple of months, so I'm really excited to have their expertise and their help and their passion join the rest of us on the team. And then the other faces you see up there is myself, our division leader, Dr. Ashwani Rajput, who focuses on colorectal cancer, and Dr. Itzhak Nir, who's a liver, pancreas, and stomach guy like myself. So.
Am I on? Okay. I'd like to add to that, we don't have pictures of them because I didn't think about it, but we have some really wonderful medical oncologists. Dr. Fachi Lee is our pancreatic cancer specialist. Dr. Yehuda Pat, who came to us from MD Anderson, who's a well-known, highly published oncologist, as well as Dr. Human Fekrazad, who is a part of our team. And they're really some of the best medical oncologists I've ever met.
And I would echo that, actually. It's been a real privilege to come here and work with these guys. And I've been lucky enough to work with some of the biggest names in oncology, both medical and radiation and surgical, and these 3 are incredible. We're really lucky to have them here. So thank you. That's the end of the commercial part. And open to questions.
You bet. That was a marvelous presentation, wasn't it? My goodness, we are so blessed to have them both here to share with us tonight. You have been given inside of your bag a 3x5 card. If you have questions that you would like addressed this evening, please feel free to write your questions on a card. If you do not want to write them down, I can certainly run a mic to you, and you can ask your question directly of our specialists. So if you have a card, raise your hand, and I can come get them from you. Great. Perfect. Excellent. Anybody else? Okay, I saw a hand go up. I'm going to go ahead and hand you these. And I did see a hand go up, so I will bring you the mic. Absolutely.
I noticed that liver cancer per se was not listed. Is that because it's generally just the end result of pancreatic cancer?
Liver cancer, like pancreatic cancer, can start in the liver, in which case we tend to think of it as liver cancer, or it can start somewhere else, like the pancreas or the stomach, and spread to the liver. it wasn't, when you ask a clinician about liver cancer, they'll immediately think about a cancer that started in the liver. And there are two main types of cancers that start in the liver: cholangiocarcinoma, which is a cancer of the bile ducts, or the tubes that transport the bile from our liver down into our GI tract. And then there is hepatocellular carcinoma, which is a cancer that starts in the cells of the liver. And that's very strongly associated with hepatitis C, cirrhosis, and alcoholism. Unfortunately, we are seeing huge amounts of hepatocellular carcinoma and cholangiocarcinoma, actually, interestingly, in New Mexico. It's still, when I say huge amounts, I mean in comparison to other parts of the country. We actually have the highest incidence of gallbladder cancer in the country and the second highest incidence in the world in New Mexico. So there's a lot going on in the liver, but yeah, that's a whole nother talk. Did I kind of answer your question?
Liver is actually one of the places that metastases from almost any cancer likes to go to. Prostate cancer is kind of the exception, but breast cancers and colon cancer, liver cancers are really not liver cancers. They're pancreatic cancer in the liver, colon cancer in the liver. But it's a very, it's the hot spot for metastases.
And it's also, besides the skin, our one organ that regenerates. So it's one of my favorite organs, but that's another story. Okay, so here's a really, really good question. Somebody says there's a 2.7 by 2.2 centimeter lesion in the head of the pancreas. The EUS and the FNA, they took out fluid and they did some of those biomarkers, an elevated CEA. And the question is this inoperable due to location, age, or other health issues? And the second question is the elevated biomarker, or CEA, caused by genetic factors? So the answer to the first question is something inoperable due to location, age, or other health issues? Due to location, no, not necessarily, unless this was something that extended to that artery that I showed on the CT scan. So without seeing the picture, I couldn't tell the person. In terms of age, I think honestly this is actually an area of interest of mine in clinical research, and I think age is a number. We've all seen patients that are very, very sick and probably weeks from dying in their 40s, and we've seen patients that are in their 90s that are doing just fine. So I personally as a clinician do not find age a reason not to operate on someone. It's how healthy they are and what other kind of conditions do they have. Someone comes into the clinic in a wheelchair on oxygen with a heart, murmur and a new heart valve, and they've had bypass surgery 10 years ago and they're still smoking. I'm more worried about that person, even if they're 60, than I am about the 82-year-old who, takes an aspirin once a year. So location, yeah, your father, patient I have in the hospital right now, 82, healthy, just had a distal pancreatectomy. Is CEA caused by genetic factors? We don't know. Is the short answer. The significance of elevated CEA within a pancreatic lesion, and it may be a cystic lesion or a fluid-filled lesion, is that it tells us that when it's over 200, so this is over 2,000 that's being mentioned, when it's over 200, it tells us that what's inside that cystic component is not watery, it's more like mucus, or more like snot, basically. And the reason that matters is it tells us that it's a slightly higher chance of being one of these pre-malignant lesions or a malignant lesion. So when we see a CEA that high, it doesn't tell me this is a cancer, it just tells me this is something at a slightly higher risk for becoming a cancer or being a cancer. So most of us, if the person was somebody who was healthy enough and wanted to go through surgery, this is something that we would try to take out. Because this is something that more than likely would be curative if I could take it out. Although there are times that pancreatic cancer can turn into a big cystic component as well. So most cystic lesions are pre-malignant. Some can actually be cancer. So hopefully that answered that. That was long-winded. This is another great question. What does it mean when a lesion is communicating with the pancreatic duct? So the pancreatic duct is the tube, the main pipe in the pancreas that drains those digestive juices that help you digest fat. And if the cystic thing is communicating with it, it just means it's draining into the duct. So that helps us narrow it down to something that is likely to be considered an IPMN, which is something that we think is a pre-malignant lesion in the pancreas. So if a cystic lesion is not communicating with the pancreatic duct, it goes into another category of diagnoses. And if it is most likely thought to be an IPMN. Now, the significance of those initials is that if you have one that's in the main duct of the pancreas, in the main pipe, those have a slightly higher risk of going on to malignancy, and we think it's going to happen over the next 5 to 10 years. If it's in one of the smaller side branches that drain into the big duct, those generally we think are going to become malignancies, if at all, over 15 to 20 years. So it becomes a numbers game when you have one of these things. Okay. We are cracking up. What can you tell us about the pancreatic cancer screening test developed by a 15-year-old who won awards for it? And we're laughing because we knew we were going to get asked that question, so we Googled it. And actually, a girlfriend of mine, I do bench research as well, and sometimes it gets discouraging because you're always looking for grants, and sometimes your hypotheses are proven wrong. And so I was feeling kind of down, and she actually emailed me that link, so it's kind of funny that you bring it up. This is an incredibly gifted, obviously, young man who found, he went thinking about pancreatic cancer, and one of the biomarkers that we look for is something called mesothelin. And what he developed was a test strip that was antibody-based that would allow you to see very low levels of this mesothelin protein. And there's some evidence that if you have high levels of that floating throughout, that you have an occult pancreatic cancer or even a non-occult pancreatic cancer. So it's a screening test, and I have a distinct feeling knowing this, seeing this young guy on the internet, that he's going to go on to try and make this a therapeutic opportunity as well. So if we can find the difference between the cancer cell and the normal cell, that's our magic bullet, because nowadays it's amazing. We can create a protein that will go exactly to that antibody, exactly to that protein, and deliver a payload of whatever toxic thing we want to deliver to it. So similar idea, he's got these little nanoparticles that are coated with antibodies to that mesothelin protein. So now, of course, the next step will be, can we get those nanoparticles with the mesothelin with something nasty to the pancreatic cancer tumor? Do stools change color quickly or gradually? Another good question. It is generally, so the clay-colored stool that I talked about is generally something that people kind of don't notice, because most of us don't spend a lot of time considering the toilet, but surgeons do, so sadly. It's something that people tend to not notice quite so obviously. And then things are a little lighter, and it's a little weird, and they think maybe they ate something funny. And then when it becomes persistent and consistently white or clay-colored, that's when it comes to people's attention. So it is a bit of a gradual change. And is this color associated with the bile duct involvement? Yes. So if the tumor is in the back part of the pancreas, it's not going to obstruct the drainage of the liver, and you will continue to have normal brown bowel movements because that bile can drain into the GI tract. It's when that tumor is at the head of the pancreas and it squeezes off the drainage of the liver that you get the no bile in the GI tract white stools.
My question involves prevention. And is there any research into chemoprevention for people who are at a high genetic risk, like you would have, for instance, the CAP studies for people with Lynch syndrome and colorectal cancer show aspirin as a possibly effective chemopreventive?
So a question about preventing the development for people that are high risk with some sort of a medication like aspirin or some of their newer NSAIDs or non-steroidal anti-inflammatories are used to help prevent colon cancer in patients that are high risk. There are people that think that calcium supplementation helps. There are people that think that aspirin may help reduce the risk. There are no particularly good links for chemoprevention for pancreatic cancer at this point, unless you're...
Don't forget caffeine.
Oh yeah, caffeine. Well, caffeine's not bad. I can't say it's good, but it's not bad, and that's good. Unfortunately, I would love to have a chemopreventive agent for pancreatic cancer, but we don't have one. So what we fall back on is, if you're at elevated risk, don't smoke, maintain a healthy weight. There is some evidence that a diet, lower in animal proteins and higher in fruits and vegetables is helpful. So you do what you can do.
I had a patient just this week that called, has family history of pancreatic cancer, and when we asked about the environmental factors, she said, well, he had the trifecta. He drank, he smoked, and he was obese. So really that, there are things that we can all do, and we always talk about when we see patients that may not have a lot of things they can do for their genetic risk, we talk about a heart-healthy life is a cancer-healthy life. And I think that's important to remember, not just for pancreatic cancer, but for colon cancer. And even if you have genetic syndromes, we know that those things are still good for you. So it's important across the board that we live a healthy life, not just for our hearts, but for our cancer risk.
Easy to say, hard to do. Yes, sir. Genetic mutations from piling up in our bodies?
The person who discovers that will get not just one Nobel Prize, but 7.
And my eternal gratitude.
Genetic mutations are one of the things that make us age. So aging we think of as a normal process, but really it's an accumulation of genetic mutations over our lifetime. Our DNA system is not a very perfect system, and there's probably some greater plan there, I don't know. I don't think I want to live forever, but as we age, we have mutations in all of our tissues. And some of those mutations cause, loss of collagen. Some of them cause cancer. So it's for the most part, a part of aging. Now, people who are born with mutations, that's a different story because they have these harmful mutations very early on in their life, from conception, really, and then those genes have a longer time to express themselves. So that's why you see the cancers earlier in these families, and it's why you see them more commonly. We don't have gene therapy yet, but that's a goal in genetic disease, is to find a way to infect ourselves with a normal gene to replace a broken gene. And again, when that happens, that'll be 8 Nobel Prize awards. So.
I would also make a play that while we don't know exactly how to prevent most mutations or certain mutations, again, the heart-healthy lifestyle does seem to be helpful. We turn on genes and turn off genes a gazillion times a day, and there are factors, I think, in our environment that affect what gets turned on and what gets turned off and what gets replicated, what is dividing rapidly, what is not. So. All the things your grandmother told you to do are probably right. Lots of roughage, lots of exercise, fresh air, get some sleep.
I was very interested, I was very interested when you were talking about the non-typical type 2 diabetes. Why do you think that is? And are there any other things that go along in that syndrome?
The new onset type 2 diabetes, no one knows if it is causative or an early warning sign. And it's something that wasn't really described. I can still remember actually the first patient that I saw in New York who had this. He got pancreatitis for no reason 2 years prior to this, and he was diagnosed with diabetes and had no risk factors. And I met him, of course, 2 years later with pancreatic cancer. And a lot of us started talking about it then, And we've since found the epidemiology studies which confirm the link, but we have no idea, is it a cause or a warning sign?
Is there any more questions? Okay, back here. We have one more back here.
With alcohol abuse almost epidemic in this country, frequently resulting in pancreatitis, can the cessation of the use of alcohol reverse the process or ameliorate the effect on the pancreas?
A fantastic question. So alcohol leads to, in most people, if you overuse it, leads to chronic inflammation of the pancreas. And somebody who's had pancreatitis, I usually tell them to think of alcohol as, you're allergic to it. You cannot have it, because if you continue giving the substance that causes the inflammation, you're going to continue to get pancreatitis. And we think it's the chronic inflammation that bumps the risk for cancer. So not only is it incredibly painful to have pancreatitis, you're causing ongoing damage. Now, I don't have the good statistics that I do for smoking, where I could say, hey, if you stop smoking today, 5 years from now, your risk is the same as mine for pancreatic cancer. I don't have that number for alcohol, but I suspect it's a shade of gray. So alcoholism is a big problem. And interestingly, actually, gallstones and gallstone pancreatitis is starting to eclipse alcoholism as the #1 cause of pancreatitis in this country. So gallstones are a big deal too, if you're symptomatic.
Wow, great questions. My goodness, what a wealth of information that we were gifted with this evening. I do want to take just a moment and give you some information. First, I want to thank our fabulous speakers. Please give them a hand. Beautiful job, and just a wealth of information. And, I'm so excited to hear the developments in pancreatic treatment for this disease, because, boy, if my daddy would have had some of that, the new advancements, what a difference some time can make. And so continued research is definitely needed and available in this area. And here in Los Alamos, we have the Los Alamos Council on Cancer. And a lot of you perhaps maybe are unaware of all of the beautiful services that we offer here. And if you are having a desire to donate, that we have had that question here this evening, we do accept donations for the Los Alamos Council on Cancer, and it does stay here local. And so if you have a desire to donate to the Los Alamos Council on Cancer, please see one of us board members, and we can share with you some more information. I also want to take just a moment, and I want to thank First Baptist Church for welcoming us to this facility and letting us use their grand facility both for dinner and for our seminar. So thank you very much to First Baptist Church. And I want to give a special shout out, thank you to the men in the sound booth. Dwayne and Billy, thank you very much for serving us this evening, and Pac 8 for being here as well. Please encourage your friends and family to seek out the information. Knowledge is power, and we cannot change what we do not know about. And so really keep yourselves informed about what the developments are to maintain a strong, healthy lifestyle, and know that those of us with the Los Alamos Council on Cancer are here to serve you in any way that we can. Also, I just want to remind you to please fill out your surveys, your evaluation forms for tonight's seminar. You will want to, if you need CEUs, you will need to turn those in to us so we can see to it that you get your CEU credits. So with all of that, yes, I did talk to them about the donations. Thanks, Paula. She's back there. She's so good. Paula, I just want to give an extra shout out to Paula because she is our president. She works tirelessly to make sure all of this happens for us. And I want to give a shout out to my friend and colleague, Monica, because of her desire to also bring PanCam and pancreatic cancer awareness to our community. So thank you for all that you do as well. So with all of that, you are dismissed. I do want to thank you so much for coming out tonight. Please feel free to donate to the Los Alamos Council on Cancer and hand in your evaluations. Thank you.